From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Cardiology Author Interviews. Thanks so much for joining us. My name is Sadiya, and I'm a preventive cardiologist at Northwestern University Feinberg School of Medicine. And I'm delighted to be joined today by Dr. Frederick Ruberg and Dr. Matt Maurer. I'm going to ask each of our guests to introduce themselves, and then we're going to get into the really exciting study that we're here for today, their article, Transthyretin, Cardiac Amyloidosis, also known as TTR amyloid, in older Black and Hispanic individuals with heart failure, the SCAN-MP study. So, Rick, I'll turn it over first to you to introduce yourself.
Thanks so much, Sadiya. It's a pleasure to be here and an honor to talk about our publication. My name is Rick Ruberg, and I'm from Boston University, Boston Medical Center, the Amyloidosis Center, and the Division of Cardiovascular Medicine.
Awesome. Thank you. And Matt?
Yeah, pleasure to be with you as well. My name is Matt Maurer. I'm a cardiologist here at Columbia University in New York Presbyterian Hospital.
Awesome. So let's get into this. We have heard over and over again, right? Heart failure is a growing problem. We're seeing an increase in the number of cases, particularly among older adults. But we're often talking about the burden of hypertension or coronary heart disease or valvular problems. And you guys focused really on this growing problem, or perhaps one that we're maybe becoming more aware of cardiac amyloidosis. Matt, could you give us a little bit of background on why you chose to focus on a cohort 60 and older, particularly of Black and Hispanic individuals with heart failure here?
Yeah, great question. The background to this disease, cardiac amyloid, is that it has a kind of an age-dependent penetrance. And as a result, it's typically seen in people who are of Medicare age, 60, 65 and above. And in particular, individuals of the ethnic backgrounds we're interested in carry a particular gene called Val122ILE that disproportionately or almost exclusively affects people of West African ancestry. So that background led us to focus on these particular individuals when we were screening for cardiac amyloidosis.
So as you were putting this study together and the cohort together, Rick, can you tell us a little bit about what the specific inclusion and exclusion criteria were and why you chose those?
Yeah, so we really wanted to kind of recapitulate what a clinician sees to make it very clinically relevant. And so we chose patients who had clinical evidence of heart failure, who are older, just as Dr. Maurer just related to you. And we also wanted to exclude patients who had increased wall thickness because, as you mentioned, Sadiya, hypertension is a major burden and often as a cause of heart failure in a large proportion of people. But our goal was to try to understand what proportion of people who clinicians might have thought had maybe hypertensive heart disease actually have cardiac amyloidosis. So we chose patients who were older, over 60, who self-identified as Black or Caribbean Hispanic, and we can discuss why we chose that in a minute if you'd like, and those who had wall thickness of 12 millimeters or more on a screening echocardiogram. And we excluded patients who had known AL amyloidosis, and there were a couple of other important inclusions in terms of renal failure. There's a clearance inclusion. We also excluded patients with a low ejection fraction because we wanted to catch patients with cardiac amyloidosis who were earlier in their disease course. So the principal sort of idea was patients with heart failure, principally heart failure with preserved ejection fraction who are older and self-identified as Black or Hispanic.
Now, one of the things I thought was interesting is you didn't particularly enrich for some of these other kind of red flags that we've heard about, like carpal tunnel. And what was the rationale for kind of casting a broader net?
I would say that we've learned a lot over the years, but we were most interested when we started this study 5 or 6 years ago at trying to really establish broadly what the prevalence of disease was before clinicians started to, tease out the potential prevalence of amyloid. And so your point's well taken. This is a prevalence estimate that is probably, if anything, on the lower end as clinicians try to think who might have this disease. We didn't enrich the population for those orthopedic manifestations, for example.
I would add that this is a study that we conceived actually right around, I'd say 2018. And it took 5 years to do this study. And a lot of the data that supported carpal tunnel syndrome, spinal stenosis, and other extracardiac manifestations really became more widely appreciated as we were doing the study. And we really did want to also we took this study from the perspective of a cardiologist. And so as a cardiology clinician, these are the patients that we see. And we really wanted to capture that population of patients to make it relevant But your point is, as Matt said, very well taken, that one could apply additional filters to increase the yield or the accuracy of, say, for example, the testing that we perform. But we really wanted to make it as clinically relevant as possible.
And for the average population of HFpEF patients that are being seen, then what did you find for prevalence and other characteristics in your study?
So we enrolled about 650 people ultimately. And I will point out that we enrolled these participants from 3 sites. 2 of us are representing 2 of the sites, Columbia University and Harlem Hospital in New York City and Boston Medical Center in Boston. And we also enrolled participants from Yale New Haven Hospital in New Haven, Connecticut. And so of those 650 patients, we found cardiac amyloidosis overall in about 6.5 to 7% of the total population. But if you restrict the population to only those who self-identify as Black, those who identified as Black race, the ATTR amyloidosis was identified in about 8% of participants, but only in about 2% who were of Hispanic ethnicity. And so that was an important observation. And then when we further looked at the stratification of age, we found that the prevalence of cardiac amyloidosis was higher in older people. So we initially had, as I said, we looked at patients 60 and older. We had a priori identified 75 as a cut point between those who were, I guess, younger, older, and older, older. And those who were over 75, the prevalence of amyloidosis actually reached as high as 17% in men. And so it's definitely something that our data show is associated with aging. And as patients were older in our population, we found a higher prevalence of disease.
The other observation where we didn't detect a big difference was actually between males and females. I think that probably is an important message at large amyloid centers like at Columbia and Boston Medical Center. I'd say 85% of the patients we see are males. And there's a very high chance, I think, that we are missing this disease as we do in many other cardiovascular disorders when people get interested in them in women. I think that's something that the field needs to tackle a little bit.
It's a really interesting observation. When we think about penetrance, there is this narrative that men are more likely to develop cardiac amyloid when we're looking from the perspective of all carriers of a genotype. But here you kind of went at it the other way, which is interesting. And then among patients with HFpEF, we're not seeing that sex predominance. So once you have signs and symptoms for the general clinician who's evaluating these patients, your point is very well taken. We don't want to bias and undertreat or underdiagnose women who may also have amyloid and benefit from specific therapies.
And our study design, by basically enrolling half of our participants as women, allowed us to see that in a way that retrospective studies have not been able to, I think, as effectively.
Which in and of itself is very impressive. We know that that's one of the areas where we see a lot of gaps, where oftentimes studies have underrepresentation of women, so you can't even get to the point where you're able to make some of these conclusions. Impressive also in the volume and sample size of patients that you enrolled, and then were able to characterize really deep phenotyping across a large group of patients with HFpEF. And so an incredible effort in being able to do that.
I also would point out that we did this during the COVID pandemic, which was even more challenging. As all of us remember, those of us who were doing research at that time, we basically stopped our operations for almost 3 months. And maybe it was even more than that. Matt would remember more specifically. And then participants were not necessarily eager to come to hospitals to do clinical research after that. It was a challenge to actually complete the study, but we're really obviously glad that we did.
What were the key takeaways from some of the detailed phenotyping that you did?
Because we are able to kind of enroll to specific targets, and as you alluded to, Sadiya, in your question, we specifically had bins of targeted enrollment stratified by sex, stratified by race and ethnicity, stratified by age, so that we were sure that we achieved adequate representation in each of those bins so that our prevalence estimates and precision widths would be acceptable and we thought would provide us with a degree of acceptable precision for our estimates. So that way we were able to look at, Matt already mentioned the difference between men and women. We were able to show in our population the prevalence of ATTR amyloidosis in the Caribbean Hispanic ethnicity population was relatively low, only about 2%. So that was actually quite interesting. And the other thing is we were really able to dig into the difference between carriers of the V142I allele that Matt alluded to at the outset of this conversation, and what proportion of patients had ATTR associated with V142I, and what proportion of V142I carriers had ATTR. And those are obviously 2 separate things. And interestingly, we found that Of the allele carriers who had V142I, only about half of them actually had cardiac amyloidosis, which is, I think, another important point of this study. These are all older people. They all have heart failure. They all have increased wall thickness. And so you would think that if they are V142I carriers, they may very well have cardiac amyloidosis. But it turns out that's only true in about 50% of them by the PYP imaging that we use to assess the amyloidosis. Maybe it was just super early disease that we couldn't detect with PYP imaging. The other thing we found also was that in this population, about half of the patients also had wild-type TTR, not V142I TTR, which I think is also an important point because it means that they could still have wild-type TTR and still have cardiac amyloidosis. And that's, I think, also really important to try to understand. Again, clinically, how do you make sense of genotyping data, which is becoming much more available to clinicians, and the capacity to identify the phenotype using sensitive imaging?
So genotype imaging could be true related or true unrelated based on the 2x2 that you showed very nicely, and really gets at how much more complicated diagnosing the etiology of HFpEF is becoming in a good way, but also that we need to be clearer about what is causing the disease to really be able to treat it.
Everyone's interested in genotypes, but to me, this study really indicates a genotype first approach in which you just look for V122I will miss a lot of people with amyloid, and that would be a catastrophe. Everyone gets old, and wild type TTR is still the most common form of systemic amyloidosis. And so I think people have to start off not with the genotype, but with clinical approaches. I was going to also just mention with regard to, the deep phenotyping, we measured multiple different biomarkers. I don't think there was a terrible surprise that those with amyloid had higher natriuretic peptides, higher troponins. Interestingly, not much difference in their estimated GFRs. New York Heart Class didn't differ, so you can't just judge based on the severity of someone's heart failure phenotype whether they have amyloid. And there were obviously marked echocardiographic differences that are consistent with amyloid increases in wall thickness. There was a discordance with the QRS voltage on EKGs, so there's more prevalence of low voltage. Interestingly, patient-reported outcomes like KCCQ didn't differ amongst the group. So it does require, I think, as you're saying, Sadiya, someone to really kind of put this on their differential and really deep dive into it in order to explore it beyond the basic clinical phenotype.
So I think we're getting to this point of how do we put all of this together and what are the key takeaways from the study?
So I think the first key takeaway is that think about amyloidosis. And I hope that all clinicians who are listening to this podcast will, when they're, evaluating a patient with heart failure, even if the patient may have hypertension, even if the patient may have aortic stenosis, because I think that one of the challenges of identifying amyloidosis is this disease develops over time, and patients may have pre-existing other disorders, but they always should have a high suspicion for amyloidosis. And I think our data would suggest that if patients identify as Black and they are older, particularly over the age of 75, this really has to be high up on the differential. I mean, I think a clinician obviously will use their common sense, and if someone's had an MI, an anterior STEMI, you're not going to maybe think about it. But somebody who has no other real explanation for their heart failure, who is older, and as I said, self-identifies as Black, I think that you should really seriously consider whether or not you screen them with nuclear imaging, which we have now for amyloidosis. And as you mentioned earlier, Sadiya, there are other potential clues that one could apply to change that. But I think that's probably, in my mind, kind of the key takeaway is think about this disease, test for it in appropriate people, and the overall goal is to identify patients early so we can get patients the best possible therapies.
And if we think ahead to where we're heading, this was a group of patients that had symptomatic heart failure, a lot with class 3, but some with class 1 and 2, but diagnosed heart failure. What are your thoughts, Matt, in terms of really trying to push the needle on prevention if you have someone who's at high risk for cardiac amyloid? Are there things we should be doing for that?
Yeah, it's a great question. Obviously, the V122I allele is inherited in autosomal dominant fashion. So first degree relatives have a 50-50 chance. I think downstream family cascade testing is highly underutilized and more so in minority populations. In particular, we need to test the siblings, not the children per se, because of the age-dependent penetrance. But I think if we do that, we're going to find people much earlier. and help them out. There is now a move toward using these targeted pharmacological therapies in for allele carriers who don't yet have disease in a prevention trial called Act Early that many sites are doing around the world. So there's a hope that with early identification, careful follow-up, we potentially could make this disease non-existent in the future, at least the genetic form of the condition. Still don't have great ways to identify those early who have non-genetic or sporadic age-related disease.
So there were a lot of lab testing that you did as well. And we talked a little bit about the BNP, which is kind of what we classically think about when we are assessing patients with heart failure. But what about the prealbumin?
I'm really glad you asked that question. So prealbumin is TTR. This is the protein that is misfolding and causing amyloidosis. And so based upon some data that was in existence at the time we conceived of this study, we decided to measure prealbumin, and we found that variant carriers, patients who had V142I ATTR, had significantly lower prealbumin than those who had wild-type TTR and those who did not have ATTR amyloidosis at all, the non-amyloid heart failure controls. And this probably indicates a degree of instability of the prealbumin. Interestingly, though, that prealbumin has probably been unstable for the patient's entire lives because this is something that people are born with. And so it's really fascinating that as people get older, ultimately this disease manifests. So it suggests to us that prealbumin instability and low prealbumin is part of the calculation, but another process associated with aging is clearly also contributing to the development of this disease. But low prealbumin can be a clinical clue that variant ATTR is present.
So we've got some physical findings that can be clues, laboratory findings, and the most important thing, I think you said earlier, is just having a heightened awareness for this in our patients with heart failure, and particularly among those who are older. And as we start to expand, maybe thinking about how we can prevent this as well as we move forward. I just want to say thank you both so much for spending this time with us and teaching us a little bit more about amyloid as well as this really fascinating study. I am Dr. Sadiya Khan, and I have been speaking with Dr. Rick Ruberg and Dr. Matt Maurer about their study, the SCAN-MP study. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks so much for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.